Hello, everyone, and welcome to this discussion about the latest result on metastatic urothelial carcinoma at ASCO GU. Together with Professor Thomas Powles from Bart's Cancer Center in London, myself, Fredrik Liedberg, who is a urologist in Malmö in Sweden, we are going to share with you some of the game-changing results presented in the meeting. And Thomas, it's a privilege to have you within 4 ears and 4 eyes and discuss.
Nice to be here, Fredrik. It's a privilege to be here with you as well, actually.
Thank you.
In your beautiful country. And
you're also the PI for 2 of the studies changing the treatment for these patients. And I suggest that we start with the EV301, which is really going to change the scenario for metastatic urothelial carcinoma. And I would like to have your thoughts about how we handle the results and compared with the Adafretinib data and when to use either of the 2 treatments in third line. Have you sort of any spontaneous thoughts about that?
Yeah, so the EV301 data, enfortumab vedotin is an antibody-drug conjugate. An antibody-drug conjugate is an antibody with a linker molecule attached to a payload. The payload is a microtubule disrupting agent, MMAE. The antibody targets Nectin-4, which is overexpressed on the vast majority, 98% of urothelial cancers. The drug was tested against standard chemotherapy, which is docetaxel, paclitaxel, or vinflunine, in patients with metastatic urothelial cancer whose cancers have progressed after chemotherapy and immune therapy. So it's essentially a disease refractory setting. The patient's characteristics were what you would expect, heavily pretreated. The overall survival was the primary endpoint. The hazard ratio for overall survival was 0.70. It reduced the risk of death by 30% compared to chemotherapy. The curves went apart and they stayed apart. The response rate was higher at 40% versus 18%. Progression-free survival was also significantly better. The drug worked across broad subgroups of patients, which was attractive. The adverse event profile, 3 of special interest, peripheral neuropathy, skin toxicity, and hyperglycemia, which require attention. It's a different type of drug, as you'd expect, with a different toxicity profile. But overall, this is a new pivotal study, a new class of drug with a survival advantage. We've only ever seen chemotherapy and immune therapy do that before. So it's incredible, really, that we now have a 3rd group of drugs that are available in metastatic urothelial cancer. And this, for me, supersedes Adafretinib and other drugs that don't yet have randomized data supporting.
Of course. I mean, Adafretinib is only phase 2 study. Still, I mean, reflecting in the there was an abstract where they investigated patients receiving EV with FGFR3 mutations, and maybe they were not as good responders as the others. So I mean, we have the evidence phase 3, but I would like to get your sort of personal thoughts how to pursue and how to develop on a personalized level, which patients, I mean, which studies will give us the knowledge to choose.
I've treated a lot of patients with FGF inhibitors and a lot with Adafretinib, and also patients with, obviously, enfortumab vedotin. Enfortumab vedotin is really good at getting control of disease, and we've seen patients with liver metastasis progressing on chemotherapy or immune therapy respond to treatment. And that's a bit unusual. And because of that, my preference would be to sequence in the enfortumab vedotin as soon as possible. So I wouldn't be giving FGF inhibitors at the current. What I'd do is I would measure FGF probably during the initial chemotherapy. And then if they do have alterations, I then would be giving the treatment maybe fourth line, or what I think will be third line, because I think we're going to talk about maintenance avelumab, and that's actually going to be part of the first line plan. So actually at first relapse, we're going to be giving enfortumab vedotin, testing for FGF, and if positive, then giving Adafretinib.
Yes, makes sense. And that brings us to one of the other New England studies. You have been PI for the JAVELIN study, giving us support for continuing with avelumab after response on platinum-based chemotherapy in the metastatic setting, and that will also be a game changer. As a urologist, I have thought of the side effects of the checkpoint inhibitors. I mean, they are not completely without dangers. I read in one of the abstracts from the meeting that there were 2 patients dying from pneumonitis. And have you any caveats to give? I mean, particular things to look out for in these patients, because they would be also seeing urologists as well as they would see oncologists.
Yeah, so the maintenance JAVELIN 100 program is another big randomized phase 3. This includes 700 patients and included those patients, again, metastatic urothelial cancer, patients who received 4 to 6 cycles of platinum-based chemotherapy, and providing their cancers had not progressed, they were randomized to receive avelumab or best supportive care, and overall survival in the ITT and the biomarker positive population was the primary endpoint. The hazard ratio for survival favoring avelumab was 0.69, which is the lowest hazard ratio we've ever seen in urothelial cancer in any trial. And what this supports is the sequencing of these drugs. Now, clearly, this is a positive trial for avelumab. Whether or not other drugs would achieve the same goal, they probably would. But my preference is, because avelumab was the drug tested, that's the one that we should give. There is a toxicity profile, as with enfortumab vedotin, but immune checkpoint inhibitors are different. The majority of patients don't run into problems, and actually quality of life is remained and maintained. But the issue is 1 in 10 patients gets quite significant side effects. And so my advice to people is, number 1, expect the unexpected, because unlike enfortumab vedotin, where you get peripheral neuropathy or skin rash, in immune checkpoint inhibitors, you can get neurotoxicity, lung toxicity, kidney toxicity, any inflammation of any organ can occur, and it's unpredictable. And so you need to have a really good team, and you need to be seeing the patients regularly. And this applies for all the immune checkpoint inhibitors. There doesn't seem to be one that's better or worse from a toxicity perspective. But there is an important team involved in that, and I agree, Fredrik, because these drugs are now going into the neoadjuvant space, the non-muscle invasive space, the oncologists and urologists need to work together, because at any time I will have a patient on ITU with an immune check. I treat maybe 200 or 300 patients, and so we'll have a patient on ITU at any time with a problem, and it will be one of a dozen different issues. And this is obviously something which, as a group, we need to educate one another. So the enfortumab vedotin program changes things and it's a Goldilocks effect. Remember, you can give frontline immune therapy, cisplatin ineligible patients, but the problem with that is you don't get in control of the majority of patients. The majority of the cancer goes straight through. And so you're better off, in my opinion, getting frontline chemotherapy, getting in control of the disease, and then getting maintenance avelumab. Some people say to me, why not wait until the cancer comes back a second time? The problem with that is not all patients who get second-line therapy are fit enough for more treatment. So only 50% of patients who second-line get treatment because they're not well, number 1. And number 2 is second-line immune therapy. Immune therapy needs time to work. And liver metastasis with bladder cancer, second-line, that are growing, you just don't have that time. So I'm saying
we have the same information in the survival curves in both INVIGO 130 and Keynote 361. The chemo has a much sort of quicker effect on the tumor.
I think that's right, Fredrik. I wondered if I could ask you some questions for a change.
Yes.
So, listen, there's a study called Checkmate 274, which is adjuvant nivolumab versus placebo in high-risk urothelial cancer patients, some of which would have previously had neoadjuvant chemotherapy and some which have not. It includes upper tract tumors and bladder cancers. The top-line results of that trial showed a hazard ratio of 0.70 for disease-free survival and a hazard ratio of 0.53 in the biomarker-positive population. It's a positive trial. What was your interpretation of it?
Well, I think that's the third game changer around this year, which sort of is very positive for these patients. Actually, in my institution, where we give more than 8 out of 10 patients below the age of 76 years neoadjuvant chemo prior to cystectomy, we included very many patients initially in this Checkmate 274. And I've also seen patients responding. That is, they have been diagnosed with a recurrence after finishing treatment in the study. So, and I also share your opinion that checkpoint inhibitors, they do not have that much side effect for the majority of patients. I've been looking through the 100 patients receiving checkpoint inhibitors in my institution, and only 10% had grade 3 or 4 detected if you go retrospectively through the patient charts. So I think, number one, not much toxicity, and we have now an instrument for these patients that we know have a very, very high risk of failing after receiving, especially those receiving chemo prior to surgery and then massive surgery, and it feels the time to give them additional treatment is directly after surgery.
What's your opinion on the overall survival and the need for overall survival? The current follow-up is under 2 years. Is it a do you need a survival advantage? And then some people say to me, well, a hazard ratio of 0.70 may not translate to an overall survival advantage. And there's another group of people who say to me, the atezolizumab adjuvant trial was negative for survival. Why do we think the nivolumab trial is going to be positive?
I mean, it's part of the same discussion as with the Powles study. I think we have accumulating evidence. I think we will get there anyway. It's not published yet, the Checkmate 274, but I think this will really be the standard based on solely on this trial. But we'll see. It's just a guess of mine.
I mean, my opinion of that is particularly the biomarker positive hazard ratio of 0.53 looks really attractive. My feeling is that will hit a survival advantage, but I'm not sure about the 0.70. Cora Sternberg's EORTC study had a PFS hazard ratio of 0.45 and an OS hazard ratio of 0.78. Now, chemotherapy and immune therapy are very different from each other, and actually the DFS may exactly translate to OS, and we may hit OS. So who knows what happens? I mean, my preference is probably to wait a little bit and see where we go with that. I think if I had a biomarker positive patient in front of me, and I think they would probably twist my arm and say, Tom, listen, I really want this. And I wouldn't blame them for wanting it either. And I think that's important, and patients may drive this.
So in your practice now, do you do upfront PDL1 staining on cystectomy specimens? Do you do biomarkers in the metastatic setting upfront to have easier to navigate the coming treatment arms?
We were doing PDL1 biomarkers on all our patients, on all samples, but that's recently changed because we weren't treating that many patients with upfront immune checkpoint inhibitors. But obviously, if this becomes a standard, then we would change. Everyone would get Of course, everyone would get biomarker analysis. One of the other areas of interest is we're doing some work with ctDNA, and it looks like ctDNA may be a marker of minimal residual disease, may be able to indicate those patients that have cancer cells left behind. And so it may be that if we combine PDL1 expression and ctDNA together, we might get the best of both worlds and really pick a group of patients, 25 or 30% of patients who really need therapy.
You're probably referring to the Tombola study from Aarhus in Denmark, where they multi-center trial randomizing patients with ctDNA positivity after cystectomy. It's the new way to do studies.
I think it's exciting. There's also some work with atezolizumab in this space, looking at the prognostic and predictive value of the atezolizumab. And, Fredrik, it looks quite promising. It's not validated, but it's looking promising. And so I think we can be combining these approaches. I think perioperative bladder cancer is going to completely change in the next 5 years. In the same way as metastatic changed 5 years ago, I think in 5 years' time, we'll have 2 or 3 positive survival trials. We'll be using biomarkers. We'll be using new drugs, including immune therapy, and potentially enfortumab vedotin. Remember, that drug's now in the neoadjuvant setting as well. It's a really exciting time in urothelial cancer.
Let's hope for that, for the patient's best in the future.
Let's do that.
Yes. Thank you very much. It was very nice to talk to you. And
Fredrik, it was lovely to talk to you as well.
Yes, and thank you for the ones listening.